The topic of today and why we're here is traumatic brain injury. And as many of you know, it remains an important topic, especially in what we call God's waiting room here in South Florida with high morbidity, high mortality. And there have been several important studies on this topic, specifically with the use of plasma in TBI. And that's exactly what we're here to discuss today. The most recent of those studies was the PAMPer trial, many of you are familiar with, back in 2020. Those studies have shown that, plasma not only improves survival, but it actually decreases the risk of secondary injuries. And I know Dr. Holcomb is going to talk about that today. So why does this matter? We as a department have connected with Dr. Holcomb to create a new protocol specifically incorporating plasma for TBI in the pre-hospital setting. And so without any further ado, we're very privileged to have Dr. John Holcomb. Many of you know him. He's a renowned trauma surgeon, one of the world's leading trauma experts and in trauma care and pre-hospital resuscitation. He obviously has an extensive research background, and he is helping us along the way. So without any further ado, Dr. Holcomb, thank you for joining us. I know you're sharing your slides. Take it away, my friend. Thanks for joining.
Yeah, Peter, thank you very much. And Charlie, thank you as well. I would encourage anybody to kind of just chime in and ask questions as we go through. We're going to cover a lot of ground, probably too much ground, but really this is just to throw some ideas out, some background and some data, and then to generate some questions and discussion and a way ahead. I do have some conflicts. None of them have anything to do with plasma and TBI. This is kind of everybody has this little quote when they give a talk and they want to do something different, but it really is true. I've been taking care of brain injured patients now since 1985, and we're better, but we really don't have a new intervention that's really made a big difference. And so, what we're really going to talk about today is not preventing the injury. That's obviously very important, but mitigating coagulopathy, expansion, and decreasing edema. Those are the things that really I think we can do something about. I don't need to tell this group TBI is a big deal. You can document it many different ways, but it's a big problem both on the military and the civilian side. Now, when you say TBI, it's kind of like saying we're going to cure cancer. There's a lot of different kinds of cancer. There's a lot of different kinds of TBI, all the way from subdural hemorrhage, intraparenchymal contusion, and then of course epidurals, and then you have combined, which is very common. So I'm not really going to get into this too much. We're going to leave it at TBI for right now. The Brain Trauma Foundation and the National Academies have focused on TBI, as you might expect, over the last couple of years. This National Academy report from 2022 kind of does a very high level roadmap. They talk about changing some names, but really it says as a nation we should focus on traumatic brain injury because it's a big problem. And maybe have a different framework and understanding. Again, not going into this, but worthwhile read. The I don't need to tell this group the biggest and most successful interventions do not occur in the hospital, and for the last 10 years, 15 years, I've largely been a hospital-based guy. Prior to that, spent 10 years in special operations in the Army and was pre-hospital, carried a ruck, slid down ropes out of helicopters, and evacuated patients back to the operating room. But uh, questions? Somebody have a question? Nope. But the most successful interventions have been pre-hospital, taking things that kind of work sort of in the hospital and moving them pre-hospital because they are time dependent. And I think the same is going to be true for TBI. I've reviewed all the current guidelines that I can find, and I would say they're pretty light on the pre-hospital and ED resuscitation of TBI patients. We'll go through some of those guidelines and some of the interventions. The Brain Trauma Foundation has looked at many of these interventions, and I'm just going to go through a couple of these. They're redoing their recommendations as we speak, and I've been in touch with them as well, and they've seen some of this information I'm showing you today. Hyperosmolotherapy, hypertonic saline, that sort of thing does lower intracranial pressure, but none of them have been proven to improve outcome. The penetrating trauma, brain trauma foundation guidelines are undergoing a review as well by the BTF. And it's interesting that many of the things that we did on the battlefield in Iraq and Afghanistan have made their way into the civilian penetrating brain trauma foundation guidelines. And the main one is that not all these patients end up dead. Certainly, if you have transcranial, both side to side or front to back, that's really bad. But many of the tangential injuries that we had a kind of a nihilistic attitude on previously have been shown to improve outcomes. And the principles of damage control surgery and damage control resuscitation have made their way into the civilian penetrating brain trauma foundation guidelines. We'll talk about that in a second as well. The uh, Greg has really is taken the lead on the pre-hospital brain trauma foundation guidelines, and if you have a chance, this webinar is worth reviewing. It came out in June of 25, just a couple months ago. It's pretty good, and I took some screenshots as I went through here. Rocco Mondo was an Army neurosurgeon. We were deployed together in Iraq. He has remained extremely involved with the penetrating brain trauma foundation guidelines, has been to Ukraine probably 10 times in the last 2 years. And, there's the obligatory pictures, but really talks about the influence of resuscitation. And he talks about one-to-one-to-one, whole blood, improving the ability of the neurosurgeons to successfully operate on these penetrating brain injuries, both in Iraq, Afghanistan, and Ukraine. Again, the neurosurgery guidelines talk about in resuscitation, avoiding hypotension, hypoxia. They don't really talk about this paper from 23, a year ago, doesn't talk about how to do the improved resuscitation. We'll speak to that in just a second. They do talk about the EPIC study that you guys are familiar with. And the EPIC study is first authored by Daniel Spate, 2019. Doesn't have a specific new recommendation, but says compliance with guidelines in the moderately or severely injured TBI patient and dramatically improves the outcome, and really talks about these four interventions: prevention of hypoxia, an airway intervention to optimize oxygenation and ventilation, not hyperventilation, and avoidance of hypotension by infusing isotonic fluids. And we'll spend some time on those as well. This, this slide is indicative of most physiologic parameters, and almost everything in the brain area that we're going to talk about has this U-shaped curve where you kind of keep the blood pressure relatively normal. You avoid hypotension, and you also avoid hypertension. These are the probabilities of increase of death. And you can see a U-shaped curve. Most physiologic parameters end up this way. This is not what we were taught when I was a resident and what I've done in the ICU. We were only taught the hypotension part, but if you really pay attention and let the data speak to you, you also avoid hypertension. And the same thing goes with temperature. Avoiding hypothermia and hyperthermia for the traumatically brain injured patient is really important. Now, if you look at the standard TBI care, and starts both pre-hospital and works all the way through the ICU, avoiding hypotension, hypoxia, all the way through working on nutrition, and serial CAT scans, operative intervention. This is what the EPIC study shows is keeping the patient and paying attention to these guidelines really does improve outcome. We talked earlier about the primary and secondary injury. We're not going to talk too much today about prevention. Obviously, it's always better to wear body armor, your helmet, avoid getting your head injured, wear your seatbelt, etc. Don't get in a crash, avoid it. But once you do, we can't avoid that brain injury, and we'll show some pictures of it in a second. But we can prevent the progression of hematoma. We can diagnose the progression earlier, and we can prevent the progression of edema. I think this is our opportunity, and this is what we'll speak about today. Now, just briefly, progression of hematomas is not rare. It's unusual, but it's not rare. What does that mean? We'll talk about that in a second. Most intracranial hematomas don't progress. When they do, mortality quadruples. So how do we diagnose this earlier? Well, right now, once you guys deliver these patients to the hospital, we wait for herniation and then get a CAT scan. It's kind of crazy, actually. We wait for lateralizing physical exam signs, but then we get a CAT scan. We do get serial CAT scans are expensive, transport's difficult and dangerous, or not at all, and just wait for physical exam signs, which is really late. There are some studies out there right now using predictive analytics. There are non-invasive point-of-care intracranial handheld hourly diagnostics that can be used and are used in austere settings. These are FDA cleared devices. We'll talk about one of them. This predictive analytics thing is pretty interesting. It comes from Marty Schreiber and Susan Rao's group that published the recombinant factor, the TXA trial. And as opposed to some of the things we normally talk about with age, sex, emission GCS, presence of midline shift, it was really the different scoring systems that are out there that were associated with progression and also some of the biomarkers and mean arterial pressure. So there are some IT kind of data analytics, AI things that are coming down the pike. But in the meantime, what we can do today is to focus on this little device, which is FDA cleared, civilian, and it's being used both in the civilian world and in Ukraine with a DoD funded study. There's a multi-center prospective randomized DoD study ongoing right now. Jan Janssen is the PI, about six different centers in the US. This could be something that we could use to diagnose the presence of hematoma and if the hematoma is expanding. Something to think about. We'll talk about that much more. Avoiding edema. This is what we really focused on the last couple of years, 20 years in the civilian world is using less crystalloid and earlier blood products. What's happened is that ARDS has not gone away, but its incidence is dramatically different. Open abdomens, the big swelling of bowel, it's kind of gone away. Extremities are less less edematous. We've seen this by not giving crystalloid and giving earlier balanced blood products. We've really changed some of these iatrogenic complications. And I think that edema in the brain can undergo the same revolution. We'll go through the data that would support that statement. This is the outline of this talk. We'll talk about endothelial dysfunction, coagulopathy, all the clear stuff that's given, drugs, and we'll end up with blood. And I'm going to use bowel and lung as examples throughout here. I'll also throw in some of the brain data. But and the neurosurgeons don't like it when I say it, but the brain is just another organ. Now it's special, right? It's a special organ, but it is different from the lung and the bowel and the liver, etc. But it's just another organ and responds remarkably in a very similar way as many of these other organs that are out there. It is instructive for just a second to go back to physiology. Physiology rules. Guyton is the best physiology book out there, and this picture comes from Guyton and talks about the different compartments. You have the intravascular compartment, the interstitial fluid, intracellular fluid, and how fluid moves back and forth between those different compartments. This is an extremely instructive figure from chapter 24 in Guyton. These are arterial pressures in dogs after different degrees of acute hemorrhage. These are without resuscitation. And I'm going to go over this for just a second because it gets to why I think that plasma may be beneficial in the brain. This is the slide that talks about autoresuscitation. I spent some time with some whole animal physiologists a number of years ago, and they taught me about this slide and then went and read about it. If you take out a lot of blood, the animal doesn't live for very long, a couple hours with no resuscitation. If you take out less blood, they live longer. And if you take about even less, 30 to 50 mils per kilo, 30 mils per kilo and or less, the animals drop their pressure, but they also then live and they bounce back. They auto-resuscitate. They take fluid from those different compartments, intracellular, interstitial, and translocate it into the intravascular. And that's how they raise the blood pressure back up. Pretty interesting physiology on translocation of fluid from those different compartments that we all learned in school and without resuscitation and how that applies to patients we take care of today. If you believe in evolution, which I think most of us do, how does that fluid happen? That fluid comes from the extravascular, interstitial, intracellular and gets back into the vessels because of permeability. This is a preserved physiologic response of autoresuscitation that is preserved across all mammals, and it's been preserved over millennia. It's a fact of evolutionary biology. Only in the last 150 years have we shown up as medics and doctors and nurses and put IVs or IO catheters and drift fluid the other and push fluid the other way out of the vessel and into the tissue. There is no edema if you don't show up with an IV or IO catheter. What we're doing is we're working against evolution. We're working against that permeability, and what we need to do is work with it. So Bill Aird publishes this book called The Endothelium, published in 2007. And what he showed was that the endothelium is very different in different parts of the body. The brain endothelium is different than the lung and the bowel. Now, they obviously have some similarities, but there are differences. Shabani Pati is a PhD that I've worked with for a long time, coined the phrase endotheliopathy of trauma, published this paper now, was that 13, 14 years ago, and kind of goes through this for a second. If you look at those spaces that I talked about, the interstitial and intracellular space, the glycocalyx, when you go into shock or has an injury, sheds. The endothelial cells become permeable. If you show up with an IV of crystalloid, then you drive fluid out of the blood vessel and into the tissue. But if you show up and give plasma or whole blood, then you restore the glycocalyx, you cause those endothelial cells to reverse their permeability, and you keep the fluid in the vessel, and you don't get edema. That was published in 2010. It really is the basis, the molecular basis of everything we've done, and I think it applies to the brain as well. Shabani has continued this work and has really led the country, I think, in articulating clearly how this happens. This is a picture in the brain now. You have even tighter junctions in the brain than you do in other places, but the same thing happens differently than in the lung to a different degree. But this hyperpermeability really occurs at the microvascular level and occurs in all of the vascular beds of the body. The secondary injury discussion in the brain now has been articulated by, again, the neurosurgeons and the neurologists around the world and the Brain Trauma Foundation. This is right out of their paper, Blood-Brain Barrier, which is another word for the endothelium, right? The brain guys changed the words, but it's exactly the same thing. Leads to excessive interstitial water, vasogenic edema. That's if you give crystalloid, right? Contributed to brain swelling, brain shift, and herniation. Right here is blood-brain barrier permeability, right there, as they talk about this. And what they don't talk is about avoiding that or repairing it. And I'll show you how that could work. Now, Jill Sundin, Mike Dubik, Charlie Wade, whole animal physiologists started teaching me this stuff a long time ago. We paid attention. Others got on board. Bijan Karabati, and then down here you see other physiologists have continued this work over many years and really have focused on permeability and started talking about the glycocalyx and started talking about biomarkers. Again, you put all this stuff together, and now we'll switch over to lungs. Shabani Pati and I and Rosemary Kozar worked together and pretty clearly showed that if you change from lactator ringers to plasma in the lungs, which have the loosest tight junctions and endothelial permeability aspects, that you can repair that glycocalyx, you can reverse that permeability, and the lungs come back looking almost normal without getting fluid in the alveoli, otherwise known as ARDS, pulmonary edema, with plasma resuscitation. Erica, who was visiting with us in Houston from Copenhagen, published this paper in the Scandinavian Journal of Trauma, which I'm sure you guys all read every month, and looked at our patients with TBI and looked and see if this endotheliopathy of trauma occurs in predominantly brain injured patients, and it does. It provides that we measured syndicam 1, which is one of the components of the glycocalyx, and supports the notions and observational studies, so you can't be definitive that the glycocalyx contributes to that physiologic derangement after TBI. Now, for the folks who've seen in the operating room, this is in the early 2000s, this is what the bowel looked like on edema, right? We don't see this anymore because we used to give 20 liters of crystalloid. We don't give crystalloid anymore. And so we don't see this huge bowel exploding out of the abdomen. This is a picture I took as my patient in 2006. We don't see that. I mean, people don't get bowel wall edema anymore, but we still see lots of edema and take out the skull so that the brain can herniate out. We see that cerebral edema today. I think that if you put these two slides side by side and go, why is this brain getting edematous? I think it's for the same reason that that bowel was edematous, almost 20 years ago, because it was an iatrogenic resuscitation injury, and we can avoid that. All right, coagulopathy. So lots of discussion about TEGs and ROTEMs and PT and PTTs and INRs. The bottom line is we can fix all those laboratory abnormalities, but do we really see a benefit in the outcome? It's a really good question, and it's one that is still floating around out there. This paper out of Ron Chang and out of our group in Houston looked at 1,000 high-risk patients, and a clinical coagulopathy was only seen 4% of the time, where a laboratory abnormality was recorded almost 40%. A clinical coagulopathy was rare, but was associated with very high mortality. The laboratory coagulopathy, on the other hand, very common, but not associated with mortality. And so I think the laboratory coagulopathy is kind of a marker, if you will, of potentially poor outcome. I also feel very comfortable in saying that we created a lot of this clinical coagulopathy back in the old days. This paper was published in 2017. Data, we were still giving a fair amount of crystalloid then. And, the patients who had this oozing clinical coagulopathy received more crystalloid. The the group out of Europe did a prospective randomized study, and they tried to correct all of the TEG and ROTEM data abnormalities, but in fact, there was no difference in outcome than if they just did ratio-based transfusion. So it's a little unclear yet if correcting that laboratory-based coagulopathy will dramatically improve outcome. All right, let's talk about the clear stuff. Now, I kind of lump all of this together: non-blood, albumin, hypertonic saline, dextran, hypertonic saline, mannitol. Hypertonic saline's on there twice. Sorry about that, because it's so important. Normal saline and lactated ringers. We've done all these for the last 40 years. There's been no improvement in clinical outcome with any of these. You talk about balanced crystalloid versus saline, but normal saline, by the way, there's nothing normal about normal saline, but they both contribute to cerebral edema. This is what the data say. Lactated ringers probably contributes more because it's more hypotonic than normal saline. Hypertonic saline and hypertonic saline dextran have been studied in prospective randomized studies funded by the NIH and DoD. This was published now, 14 years ago? Pre-hospital, prospective randomized study, no benefit in outcome. No compelling reason to adopt or practice a hypertonic saline for out-of-hospital setting for TBI. That was a pretty definitive study. And then albumin, been around for a long time, pretty expensive, not biologically active, right? So it doesn't repair the endothelium like plasma does. Also not associated with improved outcome. And in patients with severe TBI, because it's not biologically active, goes through that paracellular permeability we discussed earlier, actually increases edema and increased mortality. Now, one of the questions that people say, well, you guys are promoting plasma, isn't that pro-inflammatory? Peter Ree, over 20 years ago, published that crystalloid is more pro-inflammatory than plasma. And other studies have shown exactly the same thing. Peter followed that up 10 years later with this study as a sole author. But, these inflammatory markers, we were just not taught correctly. There was lots of opinions out there, but crystalloid is more pro-inflammatory than plasma, according to the biomarkers that look directly at this. Now, Shabani, as I said earlier, has really demonstrated that FFP and Kcentra, which is a four-factor PCC approved for reversing the coagulopathy of prescribed Coumadin, does decrease that permeability, inhibits vascular permeability, but not albumin. And these are the data that say this. So FFP and Kcentra are about the same, whereas HSA, which is the albumin, human serum albumin, and Kcentra shows no effect. So Kcentra, FFP, Kcentra here, both reverse permeability, but the albumin does not. That's important because the major protein in plasma is albumin. Albumin is made from plasma, and so you might think it would, but it's not been so processed and heat sterilized that it's not biologically active. Just the risk factors for ARDS for increasing permeability and lung fluid, which is known as ARDS in the lungs, from a secondary analysis of the prospective study, every 500 milliliters of crystalloid infused in the first 6 hours was associated with a 9% increase of ARDS. ARDS comes from that permeability issue. Any blood given within 24 hours was not a risk injury for lung injury. So when you look at crystalloid and blood together, the risk factor was every 500 milliliters of crystalloid, which of course you guys know is not that much and is pretty easy to get that much in pretty quickly. Hypertonic saline we talked about already. Does it cause a hyperchloremic metabolic acidosis? It does. Does that cause a clinical coagulopathy? So far, can't find anything that says it does do that. But remember that study on hypertonic saline from Eileen Bulger showed no improvement of outcome. And so because of this, the guidelines that came out this year from the European Society, based on available evidence, they conditional recommendation for using isotonic saline, normal saline, rather than balanced crystalloid for volume expansion. The use of hypertonic saline is not recommended, right? Hypertonic saline. So normal saline is what they come down to. Let's talk about electrolytes for a second. I was taught, and for many years in the ICU, drove sodium up, right? We drove sodium up to, quote, dry out the brain and prevent that edema. These things can, because of the different fluids we give all the times, remember that U-shaped curve. You can talk about hyponatremia, hypomagnesium, I can't even say the word, but low magnesium associated with worse outcomes. Hypernatremia associated with increased mortality in ICU, length of stay. That's what I did in the ICU for many years. And then, of course, hypokalemia and hypocalcemia associated with increased mortality. The bottom line is you kind of want to keep electrolytes normal. It's that U-shaped curve again. This is a pretty nice review of all the electrolytes in the traumatic brain injury population. Now, I just put up this little slide for a second. You guys know there was hurricanes in Puerto Rico back in 2017, and my animation didn't come through, but what's supposed to pop up here is that the gods have spoken. The hurricane disrupted the crystalloid bag supply during that time. I'm going to stop there. Anybody have any questions about anything?
Dr. Holcomb, so it's Peter here. So I'm going to let me remove the spotlight. Hold on 1 second. So we have a great audience here. I see some friendly names. I know we have many of the folks from the hospital, trauma surgeons, neurosurgeons, etc.
Good.
I would invite any of them to unmute their microphone, introduce yourself, and please comment on these concepts.
I have a question. This is Dr. Huss. There used to be medication that is off the market for different reasons. I was just wondering if you had any experience and if you can link it to what you were talking about called Zygris. Do you remember that by any chance?
Oh, yeah.
Absolutely. Oh, yeah, I do.
So it's a protein C inhibitor, if I remember right. I was just wondering, how would that fit kind of like into this? Forget what it was for initially, which was for sepsis.
Yeah. Yeah, the Zygris story I think is very interesting. I only prescribed Zygris once or twice in my life in the ICU. Um, and I think it is a drug that was given without completely understanding the mechanism of action. Um, if you give Zygris at the right dose at the right time, it appeared to have some benefit. If you gave it too late or too high a dose, it actually caused a profound coagulopathy. The When you get into the basic science of Zygris, there was two parts of that molecule, the protein C molecule, and subsequent studies have shown if you take an aptamer, in other words, you break the molecule apart and have its two parts, there's probably one part that's anticoagulant and procoagulant, and you can use them separately. The bottom line is it got taken off the market because it caused more complications than benefit.
If I may, Dr. Farsi here. Dr. Holcomb, you're completely right. I was part of the Surviving Sepsis campaign, and it was only for severe sepsis and septic shock. I don't remember. I think it was Lilly that was the pharmaceutical company that was behind Zygris, and there's kind of really it was not statistical significant, and the rate of complication of bleeding and renal failure was very severe, significant severe. And I think the Prowess shock trial in 2008 is the one that was rate limiting and determining that Zygris was causing more mortality in the 28 days. And I remember when the 2008 guideline for surviving sepsis, we were, I think, in Spain, and we all voted to ban the drug. I mean, to remove the drug from the guideline.
Yeah. Yeah, dude, I think that's right. The bleeding complications were you have to balance, right? So I kind of touched on this evolutionary biology and the preserved response, and why does the endothelium and the blood-brain barrier become permeable? I mean, that's a preserved response. How does the repair of that thing happen? It happens because plasma repairs it, this thing that's circulating around in us all the time. We got 2.5 liters of plasma in us, and it repairs the blood-brain barrier, and plasma reverses that permeability. I think we should pay attention to evolutionary biology, honestly.
So I have a quick question, Dr. Holcomb. Real quick. So based on the EPIC trial, which we did take a deep dive in here at Palm Beach County Fire, and we really educated on EPIC. And as far as pushing up the systolic blood pressure, and our protocols now do reflect that. But the problem is that in order to push that blood pressure up, we don't really have that many choices, right? It's either the clear stuff or we can choose a pressor. And so what I'm hearing from you then is that we would instead use plasma in, let's say, a volume of, let's say, I guess small aliquots, let's say 250 or 500 or more, to both increase the blood pressure and to repair that endothelium. Is that the concept here?
It is. I think that's exactly right, Peter. And it's a good way of saying it. That U-shaped curve again shows up whenever you look at biology, that U-shaped curve shows up over and over and over again, right? And if pressors will make the blood pressure look better in the blood vessel that we measure it, but at the mitochondrial level, it actually decreases perfusion to the mitochondria, right? And we got to start. We all know this, right? We all know this, that oxygen delivery ultimately delivers oxygen to the mitochondria so it can do its metabolic thing. But the pressors decrease most of them decrease perfusion to the mitochondria, although it makes the large vessel artery look better. Makes our chart look better, but not at the mitochondrial level. Again, I try to keep things simple. We'll talk about the drugs in a second. We'll talk about TXA and anything you can use. When I used to carry a ruck, if I could use something twice or 3 times, right, for different physiologies, that would be a good thing.
Excellent.
Dr.
Any other
Holcomb,
questions?
yeah, Dr. Holcomb,
Yeah.
just Dr. Farsi, another comment on Peter. I think based on that U-shaped curve, right, pre-hospitally, you really want to try to avoid both extreme, right? So the hypotension is the one you want to correct. And I think the plasma is probably one of the great option, right?
Yeah, I think you're right, David. I tell you what, I've told Peter this. If I live in Houston and I do my clinical work in Alabama, boy, if I get, I ride my bike. I rode my bike yesterday, right? So if I get a head injury, you better give me plasma. So that's what I
We're
want,
gonna,
you
well, we're
know?
gonna
I
try to
have a
make that
question,
happen.
Dr. Holcomb.
Oh, go
Yeah.
This
ahead.
is Robert Borrego at St. Mary's. I got to the lecture a little late, but I missed when you described the mechanism in which plasma is repairing this endothelial dysfunction. What's the
Yeah,
mechanism?
the mechanism is we're happy to share with you. Again, like I said at the very beginning, this is a recorded, and you guys can look at the slides, and I try to put the papers in there. The mechanism of the plasma is very interesting. It reverses that permeability of injury, and it reverses the permeability by repairing the glycocalyx, which is a mechanotransducer through the cell membrane into the cytoskeleton. So the glycocalyx sheds. It's a mechanotransducer, causes contraction of the cytoskeleton and causes paracellular permeability. So that's all been worked out very nicely. Plasma reverses that by reconstituting the glycocalyx, causes that cytoskeleton to relax and reverses the contraction of the endothelial cell.
All
It's
right,
very
thank you.
interesting, actually. It has nothing to do with the 12 or 13 coagulation proteins that we were all taught in medical school. Nothing to do with that.
No, I was just wondering if it had anything to do with, NDA channels or any other gated channels that are open in the brain,
Right.
and the subsequent oxidative damage that's done by free radicals and all those things. Sounds like it may be related to that.
Yeah, I don't disagree. There's one of the papers that talks specifically about this, and you'll see the reference when you look at the slides. And happy to send those to you.
Dr.
That'd be
Holcomb,
good.
doesn't the plasma also have like antithrombin 3 protein C that also can mitigate some of the inflammatory response that you
Yeah.
see after traumatic injury? I mean, you're also providing that as well in the
Yeah,
plasma.
it's I would, it's interesting. I know it almost sounds too good to be true, right? That it solves all problems. It clearly is not true. But Jessica Cardenas is another PhD who worked in our lab who just left Houston and went up to Denver. But she has a paper in Shock. I don't think it's in this slide deck. I'm happy to send that. If you're hypercoagulable or hyperinflammatory, if you're hyperinflammatory, brings all those functions back down to normal. If you're hypo, brings you back up. Again, it's this evolutionary biology concept that we should work with rather than against.
Got it.
Yeah, I'm
Well
gonna
said.
for the sake of time, keep going here. I appreciate the questions, love them actually, because every time I do this makes them better, and I'm happy to answer them all. We're gonna keep going if that's okay. All right, drugs. You guys are all familiar with the CRASH 2 and 3 trials. So TXA for brain injury, right? TXA for brain injury decreased mortality, right? Decreased mortality. Risk of death after 24 hours was the same. And because that kind of got washed out, the risk of death over the whole 28 days was the same. But the bottom line here was that it reduced death in 24 hours in the non-moribund TBI patients. Kind of interesting results. This paper in JAMA by Susan Rao and Marty Schreiber, 2020, also talks about TXA in TBI. Now they used the previous study used the one gram, 1 gram dosing. This study used 2 grams and 1, and then had a 0 and 0 arm as well. There were no safety issues identified, no difference in LY30 on emission tags after receiving pre-hospital TXA and antifibrinolytic. And there was no difference in the primary outcome, a functional outcome at 6 months. That's the FDA's endpoint for TBI trials in the United States. In that group that had a positive CAT scan, so only about half the patients, when you do a pre-hospital TBI trial, only about half will subsequently have a positive first CAT scan in the hospital, because it's really hard to determine. I mean, there's many reasons to have altered GCS. Doesn't mean you have an intracranial bleeding. In those patients who got 2 grams pre-hospital, very significant difference in 28-day mortality, very beneficial. No difference in GOSC, but the DRS was significantly improved. So one of the scorings on function in that group who had a positive CAT scan. And this is the results, right? So in the group with a positive CAT scan, 18% mortality in the 2 followed by 1 gram, 26 in the 1 and 1, and 27 in the 0. So no difference. The 1 and 1 TXA had no effect on mortality in TBI patients, and a big difference in the group that got 2 grams pre-hospital. And there was no, again, I would say there was no increased complications in this prospective randomized study of over 1,000 patients. Now, last year, this patch trial comes out in the New England Journal. 15 EMS agencies, almost all of them outside of Houston, I think, was the only US based group, but a first world country, did not result in a greater number of patients surviving with a greater functional outcome, both 53%. They used the 1 and 1 dosing that the CRASH 3 trial used. Yeah, I mean, I'm moving around the things. The patch also showed the same thing that the CRASH 3 trial showed, that early mortality was improved, but by 6 months there was no difference. So, what are you going to do with these patients? What are you going to do with drugs? Well, we took the Susan Rao study, the Susan Rao Marty Schreiber study, and we're giving 2 grams of TXA pre-hospital. So that's what we do. That's kind of how we put this together. No increased complications, maybe a benefit early on in the patients who have intracranial bleeding. All right, now we're going to talk about blood, which is everything we've kind of led up to and talked about already. Just to repeat, this endotheliopathy of trauma, you can look at the different organs. The mechanism, the pathophysiology is all remarkably similar. The brain is different. It has the tightest tight junctions of any place in the body. I just want to go over this one more time because it's so important. What we were taught about crystalloid and blood is so wrong. We were just taught wrong that trolley was related to blood and that crystalloid was innocuous. It's just not true. So when you look at this study published in 2013 by Bryce Robinson, 0 patients in this large study had trolley, and 505 had what we call a Crawley, crystalloid-related acute lung injury. So 505 patients had lung injury associated with crystalloid, and none had what classically described trolley or ARDS. This is the paper that we talked about earlier with Jessica Cardenas. It's really a good paper. Jessica's really smart, PhD, and has spent her entire career looking at thrombosis, so looking at the hypercoagulable part of this, where it's very interesting that plasma actually brings things back down to normal with its anti-inflammatory response. Now, Hassan Alam, over the years, has done a whole series of studies that, starting in the early 2000s. These are pig brains that have been injured and then resuscitated with normal saline, with Hexten, artificial colloid, and FFP. And you can see the different size here, that ischemic penumbra, that brain at risk that converts, and you can put objective data next to this, but you can just see it as well, the effect of FFP on that ischemic brain at risk. This is Sanalam's paper from just this year, 2024, talks about the blood-brain barrier, talks about the cytokine storm. Peter, to your point about the pro-inflammatory nature, endothelial immune function, and these, of course, all about the plasma decreasing all of these. Now, clinical data, clinical data. So if you look at this paper, this is Peter Reed's group when he was in Phoenix, Arizona, and talks about a balanced resuscitation. This is the first paper I can find where it talks about resuscitation for traumatic brain injury. Is there an effect similar to what we've seen in the hemorrhagic shock patients? And there appears to be in this retrospective study, single center, appears to be an improvement in outcome with a balanced resuscitation. A year later, when I was in Houston with Ron Chang and the group, we published our results as well with 633 patients. In the patients who received early plasma with that multifocal intracranial hemorrhage appeared to have an improvement in outcome. And we suggested that maybe there was repair of the blood-brain barriers in 2017 for patients collected from over 4 years. And then the group out of Mayo, another single center study, much smaller, pre-hospital, talked about an improvement in outcome in their TBI patients with plasma compared to red cells alone. So 3 single center studies suggestive of an improved outcome, albeit retrospective and single center. Probably in my opinion, one of the most important papers in the trauma world is the PAMPer study, now published a while ago in the New England Journal of Medicine. 501 patients, randomized to plasma and standard of care groups showed a 10% absolute reduction, 30% relative improvement in 30-day mortality. You guys, nothing we do in the hospital has this effect. And so this paper, in my mind, really drove a lot of what's happening across the country for hemorrhagic shock patients. Now, there was a group that also had brain injury. 166 or 32% had CT-proven brain injury. About a third of patients will almost always, in these hemorrhagic shock pre-hospital stays, will have AIS-3 or greater brain injury. And, the numbers get pretty small pretty quickly. 92 patients received standard care, 74 received pre-hospital plasma, but even with small numbers, there was an improvement in outcome in the group that got plasma pre-hospital. There was no improvement in the group that were transferred. They had about a third of the patients were transferred, and in the group that were transferred and got pre-hospital plasma, there was no improvement in outcome. The improvement was all in the scene responses and pre-hospital plasma. Again, speaking to timing of the intervention. One of the questions that's coming down the pike is this dried plasma. Everybody's all interested in that. Not FDA cleared. Can't give it today in the United States. You can in other places in the world. And there appears to be no difference from a mechanism point of view and outcome between dried plasma and the liquid plasma that we currently have available to us. What happens if you give plasma or blood products to people who in hindsight don't need them? In hindsight, right? Because we use blood products both pre-hospital and in the ED, and about 20% of the patients in hindsight, when the dust clears, all the studies are done, the labs are back, the x-rays are back in the hospital, there was no difference in outcome when you give 1 to 3 units of blood products compared to the groups that got more. So we looked specifically at those patients that were over triaged, if you will, with blood products, and there was no difference in outcome. So what do we do in our clinical world right now? We give 2 grams of TXA in the ED or pre-hospital. We use balanced resuscitation, and we do that to heal the endothelium, as not really measuring coagulation proteins and talking about their INR, et cetera. We do that in the TEG, later in the OR, in the ICU, but we do a lot of these things to prevent the ongoing secondary injury or edema. There is Hassan Alam, who did a decade's worth of work in pigs with plasma. There's a prospective randomized study of giving plasma in the hospital, not pre-hospital. That study is going to start enrolling here any day. That's funded by the DoD. The common themes that we start wrapping up here: minimize blood-brain barrier permeability, endothelial cell permeability, repair the endothelium. When I round the ICU, I give plasma to hemodynamically stable patients who have normal coagulation function measured by INR or TEG, and I do it to repair the endothelium. I gave plasma to an ARDS patient the other day, and almost no clear fluids. Almost no clear fluids do we give. I think there's really good mouse and rat data. I think there's really good pig data, and there's highly suggestive human data. Single center, retrospective, and a secondary analysis of a prospective randomized multi-center data. Conclusion, let's don't make the injury worse. We did that for a long time. I did that for a long time in the hemorrhagic shock patients. Let's don't do that for these brain injured patients. We mitigate coagulopathy. We mitigate and avoid the expansion while decreasing edema, repair the blood-brain barrier. What would I do today? I'd give 2 units of plasma, both pre-hospital, ED, or ICU. I'd give 2 units of plasma as a drug to the TBI patients. Now, teaser. This talk could go on forever and ever. Stem cells, very supportive data. Sepsis, beautiful animal data. Initial human data. Burns is an ongoing DoD trial, and of course the dried plasma stuff. All of this with plasma, all of it with a common mechanism of action, and all of it to prevent edema. Thank you very much. Happy to answer any questions that you guys have. Fire away.
I do have a question, Dr. Holcomb. This is Robert Borrego again. Thank you. I mean, I really enjoyed the lecture very much. And thanks for sharing that information with us. The only concern that I do have about one of the slides, it was on the TXA side, to giving it to patients with suspected head injuries, brain injuries. But I'm concerned when it's a suspected head injury, like, in our population here in Palm Beach, we see a lot of elderly people that fall, have a laceration or the scalp, but it turns out to be a stroke. And, I don't know, I wonder if you, in your practice, if you use any type of exclusion criteria to try to exclude those patients that, in fact, it's a stroke and not a TBI.
Yeah. Well, stroke is a little bit like TBI, as you know. I mean, there's hemorrhagic and ischemic as well. I need to look that up. We routinely, based on an altered GCS, in our practice, give 2 grams of TXA, and I know we've given it to hemorrhagic stroke patients before, and ischemic stroke patients with altered GCS, who fall down and bump their head, right? And we see that in the ED quite often. I'm unaware of any data suggesting any kind of negative outcomes. I actually would worry a little bit more about seizure, because those strokes will lower the seizure threshold. And if you give 5 grams of TXA, you do increase seizures. If you give 2 grams of TXA, you don't. So I think that I'd be less concerned about the hemorrhagic part. TXA does stabilize the endothelium to some degree. It has anti-inflammatory effects. And I'd be a little concerned about the seizure threshold. Peter, any thoughts on that?
I think that's a great question. My understanding is that there was a study that did show that TXA did not increase that threshold. However, in patients who already have an ischemic stroke, I think it's an excellent question. The difficult part on our end, on the EMS side of the house, is that oftentimes, not often, every time, those are impossible to tell without some imaging of some sort.
Yeah, I think so. I don't know the answer to that question. It's a great question. Don't know.
The reason why I bring it, the reason for the questions, we had a couple of anecdotal cases, like Peter suggested. We didn't know, we suspected that it was a TBI, and we treated them with the TXA, but it turned out it was an ischemic stroke. And of course, if the patient progresses, particularly the neurologists are going to blame the TXA. So my question even for us, is if we should have some exclusion criteria that we suspect the patient is a high risk for ischemic stroke, to withhold the TXA and that subpopulation of people.
So
you think that's feasible?
It's a great question. I'm not a stroke guy. It's really not the subject of the discussion today. But it's a great question. As a trauma surgeon, I get routinely asked to see people in the ED who have fallen a little bit, who have an abnormal CAT scan, lateralizing signs, and we try to sort out strokes versus brain injury. I don't know. I don't know the answer to the question. It's a great one.
Yeah, I
Thank
think
you.
that we ought to reach out to Dr. Borrego. I'm going to reach out to some people that I trust and see if we can come up with something. What you're saying is there's obvious signs of LVO, some sort of hemiplegia, where it's obvious at the moment that they are having a large vessel occlusion. In those cases, that's what you're saying, right?
Yes.
Yeah.
Great
I,
question. Okay.
Clearly, if the patient woke up in bed, like many of the, awake in bed or developed it without a history of trauma, that's a whole different story. It's the guy who falls, bumps their head after
Right.
after the stroke symptoms start, ischemic stroke symptoms start. That's your question. It's a good one.
Correct. Yes.
I do not know that.
Right.
And Peter,
Anybody else?
Peter,
Yeah, go
you
ahead.
guys
Go ahead, Nir.
give only 1 gram of TXA, right?
We've actually moved to 2 grams based on the study
Oh,
that Dr. Holcomb mentioned. So we take
okay.
2 grams, we put in a 50 cc bag, 60 drop set, we run it wide open so that it's not really a push, but it's going in over 3 to 5 minutes. And that's from, I think, the Marty Schreiber study
Yeah.
that Dr. Holcomb talked about earlier, which
Yeah.
showed the benefit, significant benefit when they parsed out the CT positive TBI patient.
And no benefit to the 1-in-1.
Right.
Really
Yeah.
interesting that they picked that. So no benefit to the 1-in-1, which may explain the patch
Yeah.
results and the
And the crash
crash
3.
three, right?
Yeah. Right. But the problem is that with TXA, the benefit on these large studies is only a couple of percentage points. Right. So you need tens of thousands of patients, maybe more, to find that small number. So it's very unlikely that these studies are ever going to be repeated again with a
Yeah,
two.
that was my main problem even with the crash true. You had to have 20,000 patients to see a 0.8% difference in
Right.
20,000 patients was significant. You kind of go, well, I don't
Yeah.
know. Typically our studies, your big studies are 1,000 patients, that wouldn't have been significant. Yeah.
Right. Exactly.
The key thing is in the trauma patient, just to go back in the trauma patients, prospective randomized data in the trauma patient have seen no increased complications from VTE or seizures.
Right.
And
So
it's key.
And Peter, if I may, David Farsi,
please.
Dr. Farsi, from a comprehensive stroke center, we're not a trauma center. If a patient has some significant bleed, sorry, my child's. If a patient has some significant bleed, and we feel that we need to use TXA to reduce it, neurology has never had a problem, so they say if the patient sees, is it coming from TXA or is it coming from their injury? So, just I'm not saying that that's evidence-based medicine, but just letting you know, like.
Yeah. Thanks, David.
Yeah. Yeah. So I think, it's perhaps a good time to open it up now for everyone to discuss and at least let your feelings come out, because we are now at Palm Beach County. We have connected with Dr. Holcomb. I have to give great credit to my team who's on here today. I saw Dr. Shepke just joined us, but our team has developed a protocol that will start to allow the provision of plasma for severe TBI patients. As everyone knows, the Palm Beach County, since July of 2022, we have been carrying whole blood. We are able to get other blood products, plasma, at a tenth of the price. Dr. Holcomb mentioned it's about $60 instead of $600. And Dr. Holcomb, I'm hearing you're saying 1 to 2 units. That's what you're saying to these patients.
Yeah, I think so. That's what was done in the PAMPer study. It is when I talked to Hassan Alam, as a good friend, I said, "What's the dose that you're projecting for your study in hospital?" And he said 1 to 2 units. Why? Because that's what was successful and gave good outcomes in the PAMPer study.
Awesome. So having heard that, and now everyone knowing that we are going to be moving towards this protocol, anyone on the hospital side, of course, Dr. Shepke, please if you want to make comments, it'd be a great time for that now as well, or Chief Coyle.
Dr. Antonio Borrego.
Go ahead, Dr.
I'm a
Borrego.
huge proponent of plasma. In fact, even before listening to Dr. Holcomb give this lecture, in the in my 33 years of working in the ICU and trauma patients, many times I've used plasma in lieu of normal saline to resuscitate a patient in the ICU, just because I believe in the plasma issue wholeheartedly.
Nice.
And I think that if we're
Nice.
going to use plasma, in fact, I know that there are papers out there that have compared giving not whole blood but packed cells to patients versus plasma, and the outcome has been better with plasma. I don't know why, the reason that is, but I do know that those papers are out there. So from me, as far as the protocol of using plasma in the pre-hospital setting, in my opinion, that's a great idea. And you would definitely have our support for that.
Well, that's fantastic. I appreciate hearing that. And I'll say that there's been a lot of protocol changes we've done that involve trauma. And I'm going to write today down because this may be the fastest we've ever come to agreement on something. So, Dr. Holcomb, thank you. I mean, I've heard your rationale for this before, and I'm totally sold on it. I think it's a great idea. Not to mention the issue. I mean, I think there's a lot of uses for plasma, including when, Peter with his outreach with everybody getting everybody else in the world on whole blood, once we get into the area where we have whole blood shortages, I think plasma has a lot of other roles other than what you're talking about. So I'm a huge fan of getting it out for this. But I always keep in mind is what other things can we use it for? And certainly we can start using it in our areas where we have a whole blood shortage or we have other potential uses, sepsis, like you mentioned. I'm looking forward to hearing more for some of those other potential uses as well. So everything we put on the truck, we try to have multiple uses. I think this is a great first step, and I'm really excited to partner with you, Dr. Holcomb, on this. I think it's going to be a wonderful rollout.
Yeah.
The only thing
just
the
to
only thing
reiterate,
that I have to
I
add.
gave a patient with profound ARDS sepsis the other day, and N of 1, okay, but he had a PDF ratio of 80, and 2 days later had a PDF ratio of 300.
Yeah, that's amazing. I'm sold on the whole glycocalyx mechanism. Actually, I think you're absolutely correct.
Yeah.
My only
Dr. Borrego, go ahead.
I still have the one concern though about patients with ischemic stroke. And the reason why I keep harping on that is because, as you know, we have a lot of elderly people that fall. They have a laceration to the scalp, and it turns out that it's an ischemic stroke and not a bleed. That's my only little concern, that I think some exclusion criteria may be warranted for those people.
Yeah, Bob, you're absolutely right. I mean, it's a big unknown. So I think, number one, we're going to have to all go back and sort of research and see if there's any other data to help guide us on that. And then we're going to have to get a little creative on the exclusion criteria. So a lot of it can be sorted out clinically, what the scenario is. But there's going to be cases, as well as I do. There are cases that you just can't tell without imaging.
And guys, I think that there's two things we can do. So I know that Charlie has worked with both St. Mary's and Del Rey to get some data back on the elderly patients who've had a fall, TXA and non-TXA. So we already have a nice population of patients. We're now going to then look forward, or it'll still be a retrospective study, but after the plasma comes in. So perhaps we'll have to look at our own data moving forward. However, I'm not sure what that sample size has to be to see a difference. I did get a response back from my good friend who I trust very well, and he says that theoretically, yes, the TXA and an ischemic stroke could make things a little worse. Charlie, Chief Coyle, do you have?
Wait, Peter,
go ahead.
It is a relative contraindication to give TXA in an ischemic stroke, right? But what I tell my staff is, if the patient's dying from a bleed somewhere and you have to use TXA to stop it or do something, then what are we treating? So I think we need to devise what patient. If the patient, like Dr. Holcomb mentioned, and the way when we were at shock trauma, patient fell from a wheelchair, did he had a stroke and then hit his head, or did he actually fell trying to get up and hit his head, right?
Right.
And that's, I think, the problem. And I think that's where, as in a pre-hospital phase, we need to also address carefully, right? If there's a relative contraindication, we have to be kind of using it with caution.
Right. So I think the only patients that would qualify in my mind are those who have an obvious large vessel, who have who have hemiplegia, as an example, who have a gaze preference. And I'll give you a story that hits home for me that my wife's grandmother was on blood thinner. She fell on her butt. Okay, she didn't even hit her head. She ended up with a big hemorrhagic stroke. She ended up with a bleed, let's say, and it was not diagnosed, not in EMS, and it wasn't diagnosed even in the emergency department because they didn't think that a lady who fell on her bottom would ever have a bleed. So I just want to make sure that we're picking out the right patients and we're not excluding the wrong ones. And I think that I don't want to overreach here, but I do agree that, we'll have to talk about it, but to see whether or not just those patients with like a dense hemiplegia or gaze preference, those who really have signs of ischemic stroke, perhaps those patients we avoid the TXA in, but we'll have to talk to the team and see how everyone feels about that.
There's a ISTAT, which we have and some people do have in their trauma bay, that can measure levels of GFAP and ubiquitin carboxylic, it's a terminal hydrolase, that are both markers that are elevated in TBI. It's a 5-minute test that basically they're using it for to say whether a person needs a CT scan of the brain or not in the face of TBI. So maybe there's a role there to kind of guess whether this is for ischemic stroke more likely or a TBI more likely. It can be done even in an ambulance if you guys have access to an ISTAT.
The only problem with the iStat here is that it's not a CLIA wave test. I'm actually doing a non-CLIA wave test, so you have to get a full CLIA lab certification, and it's not an easy task, unfortunately. Are there other things? I know John had mentioned in his presentation the scans. I know there are other devices that are coming out that are able to tell LVO versus non-LVO, hemorrhagic versus non-hemorrhagic, and maybe that's a technology that will come forward that will enable EMS without a CT to be able to detect a hemorrhage versus ischemia. I don't know.
Yeah, I put that infrascan in there just as a little bit of a teaser as well. It is pretty good. It is operator dependent. It's like an it's a near infrared, but
Mm-hmm.
kind of like ultrasound is pre-hospital. I mean, it's operator dependent, but it's very trainable. And I put that in there just to kind of raise the question. I need to add a slide on the biomarkers here. It's a great point. I'll add a slide on biomarkers. Pre-hop, they cost about $300. The little the little cartridge is not cheap, and I don't know what those biomarkers do with ischemic stroke versus traumatic brain injury or hemorrhagic stroke. I don't know the difference between them. I need to find.
They're cleared for TBI in general, not necessarily for ischemic. So I don't know. I didn't look.
Yeah, I know that. Believe me, that DoD funded all that stuff the last 20 years. I don't know if those biomarkers are elevated in ischemic stroke as well. I don't know that. It's a great question.
Excellent.
Hey guys, it's Robert Borrego. I gotta leave. I've enjoyed the lecture and the discussion. Thanks very much, but I gotta get going.
Okay. Thanks, Dr. Borrego.
Thank you.
Thank you,
Dr. Holcomb.
Yeah, anytime.
Thank you.
Yep.
Chief Coyle, before we drop, are you able to just very rapidly discuss what the protocol looks like as far as inclusion criteria, or is that for another time?
No, it's very simple, and I'll send it to the group here, right? So basically what the purpose of today was, number one, just to bring this new concept up, directly from Dr. Holcomb and all the research and time he spent looking at this. And then the second part was, asking the hospital for the data. We have St. Mary's and Del Rey's data, which I'm going to share with this group here. And then basically go back to the drawing board with the protocol from whatever came out of the meeting today, make sure our team feels good about it, and then share it with this team. Basically, the protocol that you're going to see for our TBI is the same protocol as what we had before. GCS of 12 or less that would have gotten the TXA is just going to be getting the plasma with the TXA. So we basically kept the TBI protocol the same, but we've added the plasma portion into it. So It won't be significantly different. Our overview for this is we have 9 EMS supervisors that are out on the road every day. All 9 of those supervisors carry TXA. Only 6 of those supervisors carry whole blood. All 9 of our EMS supervisors will carry the plasma if we're able to, obviously if it's in stock, if we can get it. So basically TBI, less than 12 on the GCS, hypotension, etc., would be treated now with saline. We would be giving this to plasma, whether it was normotensive or hypotensive. Plasma would be the go-to for us.
And Dr. Holcomb, based on what Chief Coyle just said, how many patients would we need ultimately, based on the data you had shown before, how many patients would we need to actually see a difference to see if this is working or not, in your opinion?
Yeah, Peter, I would go back to that secondary analysis of PAMPer.
Yep.
And do a power analysis, but I think this is a 1-year retrospective study.
Okay, good. That was really my question.
I think that's what we agreed on with Dr. Zidek, right? And Dr. Holcomb last time. I wasn't able to be on a meeting, but I think that's what we said, 1 year.
Yep.
We won't get to the statistical significance and getting an N number until we know where we at.
Right, and we have to see our volume. So Charlie, do you have just a big round number on how many these types of TBI patients we would see in a given year?
So we had a little bit over 100 patients between the St. Mary group and the Delray group. And the St. Mary group and the Delray group got the same spreadsheets. We had a group of patients that qualified by their GCS score for TXA, but didn't get TXA. And the only reason that would have happened is our EMS captain wasn't on that call. So that's group number 1. Group number 2 is same criteria, but got the TXA because the supervisor made it to the call. So essentially, by looking at a year's worth of data between both hospitals, we had over 100 patients that would have qualified to receive the plasma therapy if the EMS supervisor arrives on the call.
Okay, great. And then Dr. Holcomb is putting up the total number of patients was less than 300. It looks like 166. So it's about, what is that? 258 is the total number of patients they had there. And they showed, I think it was 32 versus 22% difference. So, have there been any other folks pre-hospital, Dr. Holcomb, that who have done this or are doing this?
No.
Good. We want to be first.
Yeah, the Mayo guys did a little bit, very small study. That's in that, there's 3 papers that talk about plasma and TBI. The Mayo guys did a very small study. I don't know if they're still doing it. But in the progression of this, the progression of studies, the way this works, it kind of gets there. The preclinical data is better for this effort than anything I've seen, the preclinical data. The clinical data is highly suggestive, to include a secondary analysis of the PAMPer study. We have better data for this question than anything in resuscitation and blood that I've done in the last 20 years. Well, so you guys are poised to do this. Somebody will do a prospective randomized multi-center study. This is the next best thing that you're talking about.
Right. Plus it sounds like you're already doing it clinically in the hospital.
It is, but it's not, everybody varies a little bit. This is the next step.
Right.
Peter,
Yeah,
really
for sure.
It's such an important next step, and I really congratulate you guys for going down this pathway.
Well, we appreciate all of your support and your guidance. This was a great presentation today. I know we've taken some people's time today. We really appreciate you coming on today. We love the partnership and the collaboration, and you're going to hear from us. Chief Coyle will send over some information. Thank you for sending over your data. Charlie, Chief Coyle, any last final words before we go?
No, I'm just so thankful for this entire group. I look at all the names on here that I've been seeing for the past 15 or 20 years in the county, and I know how busy each and every one of you are, including Dr. Holcomb, taking time out of your day. So thank you so much for your leadership, Dr. Holcomb. Thank you for the leadership in Palm Beach County and taking care of, all of our trauma patients, whether it's on the north or south end. and hopefully we can continue to partner and do some great things together. So thank you to this entire group.
That's good. You guys, I'll send the slides to you guys. You can send them wherever you want. Doesn't matter.
That'd be great. If you can send it to me, then I'm going to put this presentation together. I'll put it up on in a video format and send it to people. Appreciate that.
That's good, guys. Take care.
All right. Thanks, everyone. Bye-bye.
Thank you.